Hello, future nurses, back again. I'm going to be covering, hopefully, in this whole entire video, Unit 10, anger, aggression, violence, neglect, abuse, intimate partner violence. There is quite a bit that we'll be going over. I'm going to skip this video, but basically, none of it should be shocking to any of y'all. Hey, rate of violence in psychiatric facilities and substance use treatment facilities are doubled. If you work in the ER, if you work in psych, if you work in geriatrics, we have a higher rate of being exposed to violence than nurses in other areas. And let's face it, nurses as a whole, high rates of experience violence. So we have a few words we're going to start out with. Anger. Anger is an emotional response to our frustration. Aggression is an action or behavior that results in verbal or physical attacks. Violence is intentional. Is an intentional use of force that could cause injury to someone else. The biggest thing to think about when we are talking about anger and aggression is that we want to prevent it. I want to intervene before there is a problem. And some of it at the simplest, right? If we talk about it, if you're upset about something and someone has ever told you, like, hey, just calm down, right? That will escalate it. That is the time when we're just starting to get upset that we want that intervention to occur. Risk factors. Again, genetics. There are some people, especially some of our disease processes, where individuals are more likely and more predisposed to have aggression, right? To become more easily frustrated, to become angry. Remember, we talked about all those impulse control disorders, right? Our conduct, our intermittent explosive disorder. We do see certain neurological conditions that can affect anger and aggression, brain tumors, Alzheimer's, TBIs. Neurotransmitters. Serotonin is actually our neurotransmitter associated with anger. However, our whole limbic system, our amygdala, they all get involved. Hippocampus, we could honestly bring the hippocampus in, our prefrontal cortex, the whole brain, um, all of them combined. Behavioral theory, anger is an emotion, right? It's a response to a threat, real or perceived. So if you think something is going to be hurting you or someone you loved, right, we get angry. Um, it could be a bunch, right? Social learning theory. Children learn by observing and imitating others, especially if aggressive behavior is rewarded. So what do we have to do? What are we looking for when we have someone who, right, anger? Do they have a history? What has happened before with this patient? What makes them angry? Right? Honestly, y'all, assessing anger is just like assessing pain. How angry is the patient? What makes them angry? What makes the anger better? Right? All of the same questions. Um, increased demands. Is there something that triggers them? Right? What signs and symptoms can we see when they're angry? Are they irritable? Are they frowning? Are they pacing? Are they clenching and unclenching their fists? Are they punching the wall? Any change in behavior for what is typical to that patient, we want to be able to recognize and address before it gets too early. So in that history, we really do want to look at the triggers. Trauma-informed care, right? We've talked about this before. It's the idea that disruptive patients have a history that includes violence and victimization. So we want to focus on those past experiences, that violence, how it played a role in their life, and we want to not re-traumatize our patients. Continually assess what our patient is looking at, and that environment is a big one. I know we have seen it at clinical if we're not, right, staff inexperience, overcrowding, if we're not setting limits, if our patient's getting frustrated, if we're not watching, right, if we're short-staffed and the patients, we're not watching them for a few minutes, that is when we tend to see violence come in. Self-assessment is a big one. If we're getting yelled at, it's going to start to make us angry and aggressive. So we need to be looking at ourselves, be aware of our own strengths and weaknesses, be aware of our needs, our vulnerabilities, and we need to recognize our word choices, right? Our tone of voice, our body language, our facial expression even. Sometimes we as the healthcare provider needs to, I have to admit I've done this. Sometimes we need to tap out. Sometimes we just need to be like, listen, it is too much for me today. I need to take a break. I did that once. I called a code and it was a code for a psych aggressive patient, but The patient, while they were minorly aggressive, not enough for me to put them in restraint or seclusion, but I called the code because I was like, I'm done. I need to leave. And we were short staffed, and I called the code, and people responded, and they showed up to the unit, and I went to the cafeteria. And I was like, I'm taking lunch. Y'all are here. This is what's going on. Watch her. Someone else try to de escalate because I was not in a place to de escalate her anymore because I was already so upset, so frustrated. So when it comes to implementation, again, we want to intervene before any signs of escalation. We want to approach the patient in a non threatening manner, right? We want to have that relationship with the patient. And one of the best things to do is just have numerous brief, non threatening interactions. Talk about the weather, sports, music, right? Get to know what interests the patient. So that's why when something happens, we have that to fall back on. We want to look at how we're talking to staff. We want to use short, simple sentences. Have a relaxed posture. We want to definitely keep our safety. We don't want to be too close to the patient. But a lot of that safety stuff we've talked about. I don't want to have on a lanyard because that can easily be grabbed, right? I don't want to be short staffed and be just by myself with a patient who's aggressive because that puts me at risk. Um, I don't want to block the doorway. I want to be familiar with the exits are. I want to be aware of what's happening with this patient and maybe be like, hey, I can see you getting anxious. Can I get you a PRN to kind of figure it out? In that implementation, de-escalation techniques maintain patient self-esteem and dignity. I want to get everyone else out of the way. Usually, if that person is escalating, I cannot get, I, we might be able to, but we might not be able to get that upset patient to leave. So I may have to get everyone else out. I have to be honest. I don't want to argue, right? Straight, I understand this is frustrating. Let me see what I can do. Most of the time, the patient is escalating if we talk about healthcare in general because they're not being heard. And just being there sometimes to listen can help. Clear, simple directions about what can happen. Um, Anxiety, antipsychotic meds are usually what we're using. Um, Anything from hydroxyzine, Atarax, Visceral, to Zyprexa, Geodon, Thorazine. Usually the joke is that B52. The kids always called it the booty juice. Benadryl, Haldol, and Ativan combination. There's a wide variety. We want to try coping skills that work for the patient, but again, I can't be like, let's take some deep breaths. Let's do some yoga. Not always going to work. I want to approach the patient with other people, and as a last resort will be seclusion and restraint. I have to try everything else before I can go to seclusion and restraint, or there has to be clear danger to self or others. Patient punching the wall, I cannot restrain them. Patient throwing toys and hitting other kids, absolutely going to restrain them. Patient punching a solid brick wall, I'm going to let them punch the wall. Patient punching glass, I will probably restrain them. Glass gets broken. So we do have to be mindful. Restraints, seclusion can never be for our convenience as a punishment. Our priorities when we talk about restraint and seclusion, and I copied this straight from your textbook. Protect patient from harm and self. Legal requirements. I do not need an order to restrain a patient. If I have someone and they're escalating and I'm like, oh, hey, let me call the doctor to get an order for restraint, is that doctor even going to answer the phone? I don't have time to wait. Very similar to CPR. If we have a patient who, we call a code blue, I'm not calling the doctor to ask permission for CPR. I'm going to fill the doctor in later. Same thing. So if I have someone and the concern is safety, right? They just punched someone. I am going to restrain them. And then legally, as an RN, I have 1 hour to call the doctor. Within that 1 hour, I have to call the doctor and have to say, hey, this is what happened. I need an order for restraint and seclusion. I get that order. While the patient is in seclusion, they need one-on-one observation. Someone needs to have eyes on them at all times. As the nurse, we are checking on that patient every 15 minutes. Usually a tech sits the one-to-one. We check in every 15 minutes and we're documenting what's going on. Now, there are some differences between restraints and seclusion. If the patient is in seclusion, I'm just pretty much going to peek in and make sure that they're okay. If they are in restraints, vital signs every 15 minutes, we're checking for blood flow, right? We're checking for that the restraints are not too tight. We do have to give the patient a chance while they're in restraint and seclusion for food, fluid, and bathroom. Now, psych restraints are not too long, so this is usually not a problem. But if we have a patient in restraints and they're like, hey, I have to go to the bathroom, I have to give them an opportunity. If they're in restraints, usually it's about 2 hours or seclusion, that's when we have to provide food or fluid. Documentation is the other big thing. We usually have a straight packet, all this information that we need that goes over, and we can see here what was the patient's behavior prior to, what did we try before we tried to restrain the patient, what are other interventions that we're doing, what's the plan of care, how are we going to continue to assess this patient. When we release the patient, we don't want to just like open the door and kind of let them go. If I have a patient who's in old school 4-point restraints, I'm going to release like the left leg first, right, to make sure they're not kicking me. After the left leg, I'll go to the right leg, then I'll start moving to their arms. If we're talking about seclusion, we're going to have the patient kind of sit in a back corner. I want you to sit in that back corner, and they're going to sit calmly, and then I will work towards opening the door. We have to think all these restraint tips, right? Physical holding against will is a restraint. Side rails up in a bed is a restraint. Blocking the doorway, tucking sheets in so tight, and I cannot have standing orders for seclusions or restraints. This is kind of some things just on that posture. We want to have that kind of side stance. It makes it easier to move away. Have a relaxed posture as we're approaching this patient. We'll watch a little bit. This guy does a good job de-escalating. We'll watch this in class. So these are just some scenarios on if we should or should not apply restraints. Just kind of be familiar. And again, some of these are medical. So sometimes y'all know those better than me. So moving on from anger and aggression, what are we going to look about with kids, older adults, and intimate partner violence? So we have a few different types of abuse. Physical abuse, infliction of physical pain, bodily harm, slapping, punching, hitting, choking, pushing, restraining, burning, throwing. Sexual abuse, any form of sexual contact or exposure without consent, or if the victim is incapable of giving consent. So this includes rape. It includes having kids watch porn. Emotional abuse, undermining self-worth, criticism, humiliation, isolating. I wish you were never born, right? If we tell grandma and grandpa, like, I'm just going to put you in a nursing home. If we're talking about elder abuse. Neglect is one we tend to think about. We tend not to think about. Neglect is the most common type of family violence. Failure to provide for physical, emotional, educational, or medical needs. Not taking the kid to the doctor, not getting, not feeding them, letting the kids kind of just do whatever they want. And that again, minor. That's a minor neglect, but neglect we have to remember. Exploitation and economic abuse, more so in adults and our older adults, controlling resources and finances. For kids, it could be not letting them go to school, not letting someone have a job, not having someone have access to, bank account, checking accounts, using grandma's money for us. Specifically, child abuse is any of those that occur in a child. We have some risk factors. Younger than 4, kids who are different. So kids with autism, ADHD, Down syndrome are at higher risk. If you don't live with parents, unwanted pregnancy, if there's some reason parents and child aren't bonding, so substance abuse in that parent, mental illness in that parent, all of those can kind of increase that risk. If we have one type of abuse, more likely to have another type of abuse. We have some characteristics of an abusive parent. They themselves have a history of abuse. Low self-esteem, drug and alcohol abuse are huge when we talk about any of our types of violence. Unrealistic expectations. Do we expect our 2-year-old to be potty trained? If the parents can't struggle with their own frustration or any history of impulse control. And honestly, impulse control and drug and alcohol go hand in hand. So intimate partner violence is with someone you're in maybe a romantic relationship with, right? Spouse, boyfriend, girlfriend, whoever. And again, we have a few different types. It could be physical violence, it could be rape, sexual, it could be psychological, stalking. I like to talk about Joe from You as a wonderful example of intimate partner violence. Um, Most of our victims are women. However, it could also be males. Um, we tend to have it underreported in males because they just don't want to report it. So we don't always have the best numbers. Risk factors: males who believes in male dominance, jealousy. Um, when we talk about Joe from You, he thought this was like the best relationship. He was constantly like tracking and wanting to stalk these individuals. Again, we see substance abuse. And I know y'all are going to talk about this in peds, but pregnancy. Pregnancy may trigger that violence in individuals. Technically, usually what we see is they move towards independence. Hey, you know what? This person's been abusing me. I'm pregnant. I don't want this for my kid. And then when they try to leave, leaving that relationship can increase. We have a few stages that we tend to see in intimate partner violence. The serious battering phase, acute battering stage, however we're going to call it, is when tensions peak, and usually there is some type of trigger that causes that violence. So this serious battering phase is where we tend to see that violence. After that violence occurs, we move on to the honeymoon phase. And in the honeymoon phase, the abuser is usually super kind. They're very loving. Let me buy you flowers. Here's presents. I'm never going to do it again. I'm so sorry. I love you so much. I need you. And the victim in that honeymoon phase, any plans that they made to want to leave have gone out the window. I'm loved. I'm needed. It's going to be different. All of those things will change. Eventually, though, we wind up back in what's called the tension building phase. And the tension building phase, maybe there's like insults, maybe a push. And, we're like, you know what? He said he loves me. He's never going to do it again. So the victim tends to ignore or accept that behavior, in part because they don't want to say anything because they're afraid of escalation. The abuser is then rationalizing that the behavior is appropriate. And as the tension is building, both participants want to reduce the tension. The abuser may reduce tension with, right, drugs, alcohol, and the victim may reduce tension by minimizing the importance. Now, some researchers, some experts believe that tension gets so high that the victim does something to trigger the acute battering stage because they know if I just get it over with, we're going to go back to that honeymoon stage where he says he loves me and everything is perfect. So it's a nasty, vicious cycle. And it just goes on and on in a circle. So our nursing considerations: don't be judgmental. Um, that's really going to be a hard one. Remember, sometimes as nurses, we're the ones who are taking care of the abusers. And we might know the person is abuser, and we just kind of got to roll with it. We can't, well, what did you do? How did you act? Maybe you caused it. Maybe if you wouldn't have burnt his dinner. We can't say things like that. Education and resources are going to be our big one. Um, how are we talking? How are we interacting with this patient? You know, all of our therapeutic communication that we talked about, where that comes back into play. Oh, I remember when my husband, did this, or oh, my college boyfriend did this. We can't say stuff like that. We just have to be supportive and assess the patient. Education and resources are usually geared to how to leave. I can't tell the patient that they should leave. Hey, you really need to leave. This relationship is very bad. It has to be the patient's decision, but I can provide them education on like women's shelters, where to go, phone numbers to call, what to take with them, right? Sometimes these things happen suddenly, so have a plan in place. Hey, listen, I know it's really hard. It is sometimes good, I know you don't want to leave right now, but to have that plan, right? So make sure you're packing or have easy access to your birth certificate, your driver's license, any medications that you may need, a change of clothes, right? While packing, make sure you leave, don't try to get toothbrushes and makeup, hairbrushes, leave that all at home. Toiletries can be left. Medications, IDs, credit cards if you have a social security card. Those are the things we're going to kind of want to tell them to find. In our older adult abuse, financial abuse, again, is a big one. Stealing money, taking money. There are some companies, Me and My Movies, there is a movie, I think it's Netflix too, called I Care a Lot. And it's about a group, an individual who basically goes and finds these old individuals who don't have family members and becomes their guardian. And they basically say, hey, this person can't make decisions. I'm now their guardian. They take all their money and property and stick them in a nursing home and forget about them. That is a big thing if we're talking about our elderly. Risk factors for older adult abuse. If we have a single caregiver, bonus points if that caregiver is a family member who lives in the house. They have poor mental, physical health. They are dependent upon the perpetrator. Female older than 75 who is white who is living with a relative. An elderly father who is being cared for by a daughter he abused as a child is at higher risk. An elderly woman who's being cared for by a husband who abused her in the past is at higher risk. In our assessments and this is again just all of abuse, we have to screen all patients for possible abuse, right? Do you feel safe at home? And when we ask that question, we want to ask the person on their own. Every time I take my kid to the hospital with the doctors, I always laugh because they always ask him, do you feel safe at home while I'm sitting next to him? Well, statistically, as a biological mother, I'm more likely to be the person who is abusing him. So we have to make sure we're asking it. Physical signs of injury, bleeding, burns, bruises, we have to figure out what happened. Any type of bruises on an infant less than 6 months, especially, or someone who is not walking or crawling. We want to let the person talk, open-ended questions. We don't necessarily want to interrupt. We want to give them a chance. We want to try to have the victim alone and not with the perpetrator or who we suspect is the perpetrator. But we also don't want to leave someone who was just assaulted alone. We want to stay with them. We do have increased risks of suicide, homicide, and higher rates of drug and alcohol abuse. Again, self-assessment. How are we feeling through it? It can be hard on us, especially right child abuse. There's a lot of people who are like, I just can't do kids. But being able to recognize that is super important. If we're talking about abuse, we want those detailed records of the case, and we'll talk about some type of forensic nursing coming up in case this goes to a legal case. Other things to think about. We are mandated reporters as nurses. So if we suspect child or vulnerable adult abuse, we have to report it. And it gets tricky because if I have a 24-year-old who husband, just beat her up, I can't necessarily report that. But if I have an 80-year-old with Alzheimer's who's getting abused, I have to report it. If I have a 23-year-old who has developmental delays, right, intellectual disability, I have to report that. Biggest thing and best thing you can do, your facility should have a procedure for reporting that falls in line with Texas's rules. And we'll look at the Texas Penal Code. Education, information, safety plan, right, what to take. We've kind of already talked about that is a big one. And a lot of that health teaching and promotion. I know in peds, hopefully y'all have talked about this, with the new parent, it's okay to put your baby down and let him cry, right? Step out, take a break. It's better than shaking up. What can we do to attach to our children, to take care of them? If we have someone who witnessed violence when they were younger, all of a sudden becoming a parent could be harder. So we may have to have some kind of specific ones to help them learn to recognize these behaviors and situations that might trigger violence. So this is specifically like Texas Penal Code, right? It's a fine. You have 24 or 48 hours to report suspected abuse or neglect. Important thing to remember is over COVID, we saw rates of abuse decrease because kids weren't in school and the people who normally would recognize and report it didn't. So it is out there. We have to pay attention. We've talked about prevention repeatedly throughout the quarter, primary, secondary, and tertiary. Primary is what are we doing to prevent it? So teaching coping skills to kids and new parents. When I was in the Army, we could not discharge from the hospital when our kids were born if we did not go to a don't shake your baby class. I'm sure there was a better name for it, but that's just what we all called it. I had to go to a class where they taught me not to shake my baby, or else they would not let me discharge from the hospital. That's primary prevention. Anything that decreases risk factors. So honestly, substance abuse treatment could be a primary prevention for violence and aggression. Secondary prevention is our screening. Community resources, when you go to the doctor and you're like, oh, hey, blah, 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 those are the different things that we're going to want to look for. Do you feel safe at home? That is a secondary screening question when you go to the doctor. Tertiary is after the fact. Are we support groups, advocacy programs, different shelters to help? All of those different things, that is what we're going to look for in tertiary, the after the fact. Primary prevention, the violence and abuse hasn't occurred. Secondary prevention, it's occurring, but we want to recognize it early. And tertiary, it's already occurred. What can I do to make this patient better in the long run? Interventions, therapy for everyone. For everyone, individual, family groups, support groups, they all work so very well. Long-term therapy is needed. Switching gears, sexual assault. Almost done, y'all. Most of these are going to be words y'all are familiar with. We're just going to kind of go over them. So sexual assault and sexual violence, any type of unwanted sexual advances, rape, harassment, sex trafficking, date rape, drug facilitated sexual assault, incest, female genital mutilation, all of them kind of fall under that umbrella. Rape is specific to penetration with a body part by a sex organ or another type of object. It doesn't always have to be a body part. Attempted rape, the person was trying but got interrupted. And then when we look at our offender and victim, we have a few different types. Spousal rape is a thing. Just because you're married does not give your husband free reign. And the other thing is acquaintance, right? Date rape. I know the person. So when we look about date rape, we have our date rape drugs. They're often combined with alcohol. It is so easy to just slip something in a drink, and it drugs the victim. They are unable to fight the perpetrator. Amnesia is very common, so the person does not become a reliable witness. Because the patient, we just tend to think they're intoxicated, and that's why it's occur, we often don't screen them for rape. So if we have anyone, y'all best practice, anyone who has been sexually assaulted and they are intoxicated, we should be screening for date rape drugs. We should treat it like a rape. We should screen just to get it because let's face it, we don't know. And date rape drugs have a whole bunch of others. Risk of seizure, risk of vomiting, aspiration can all go, that danger with date rape drugs can go hand in hand. So if we have someone who was recently sexually assaulted, raped, going back, we have that acute stress disorder. Acute stress disorder is those thoughts and feelings that occur right after the event happens. It's kind of like that short-term PTSD. So flashbacks, memories, disassociating or avoiding things that remind them of the event. Very hyper aware, looking at what is going on, nightmares, unable to sleep because of it. Acute stress disorder happens initially and then it can progress into post-traumatic stress disorder if not treated properly. So we really do need to get this patient into some type of therapy and connecting right on. And it takes a long time to recover from this. So we very much do have to go slow. And like how we talked about with PTSD, I want my patient to be eating and sleeping and going out with their friends again to kind of know that they're doing better. Now, we do have a specialized nurse. So we have a forensic nurse called a sexual assault nurse examiner or a SANE nurse. This is our RN. Usually they want you working in like an ICU or an ER, not psych nurses, ICU or ER, because they want those medical assessment skills. It is a 40-hour class, so that is it. 40-hour class plus a whole bunch of continuing education, hands-on training like clinical hours to become a SANE nurse. So this is a nurse who has extra training in culturally responsive, age-appropriate training, Evidence collection. Honestly, one of the biggest things the SANE nurse does is that evidence collection, that chain of custody for, how can we take this to court? Um, there are a lot of things a SANE nurse is going to do that is very specific, right? Safe environment, not leaving the patient alone, but not having the perpetrator there, doing that head to toe assessment, doing that forensic exam. And then one of the biggest is that preventing revictimization. When we talk about preventing revictimization, this is honestly like multifaceted. If we're talking, the patient and I'm about to do an exam, I'm going to ask them to sit on the exam table, not the bed. Because I don't want to call it a bed because I don't want that patient to associate this exam with their bed. And right, oftentimes if we're thinking rape, that rape could have occurred in a bed. If the patient does not want part of the exam to happen, we're not going to try to talk them into doing it, right? So the SANE kit, the evidence we get is what they need to go to court if they want to press charges. But if the patient's like, no, I don't want pictures taken, we're just going to say, okay. And part of that is because someone likely just tried to coerce this patient. We are not going to coerce them too. So there's a whole lot that we can do when it comes to preventing that revictimization. So best practice guidelines involves 5 steps. Even before we get here, the first thing we have to do is develop a therapeutic relationship. So honestly, even before these 5 steps, I want to develop a relationship with that patient. And it sounds silly. And again, developing a relationship does not mean we're best friends and we've been talking for months, right? Developing a relationship just means, hey, in that moment, being there for that patient. When we think about it, if I'm about to go do this genital exam, I'm not just going to walk in and be like, hey, my name's Julie, I'm your nurse. Let's spread your legs and get this started. I'm going to take just a few minutes and introduce myself and explain what is going on to that patient prior to starting to the exam. And that a lot is that how we prevent that revictimization. So head to toe physical assessment for signs of injury, that detailed genital examination. An important thing that's going on as we're doing that physical assessment is we're asking the patient what to do. And what I mean by that is I'm saying, hey, I have to clean underneath your fingernails. And I'm going to explain to them, I'm going to take this, I'm going to kind of just scrape what's under your fingernails and collect that and this, packet. Are you okay if I do this? And every step of the way, I'm asking the patient's permission. I'm explaining what I'm doing and I'm asking permission. And by asking permission, we are giving the patient some of their power back. That goes a huge way in that preventing revictimization and helping that patient heal. So we prevent where we get the evidence. Document is a huge because we could be called to court as an expert witness. And then we help with the treatment plan and follow up. Usually this is about 4 hours. We can kind of see if we look at all the different things that could be included in a rape kit. It is about a 4-hour process that SANE nurse is there with this patient to kind of go through everything. We don't rush it. Rape trauma syndrome is a nursing diagnosis. It is not a medical diagnosis. It is a sustained and maladaptive response to any forced, violent sexual penetration against the victim's will and consent. We have some defining characteristics, and again, this is a nursing diagnosis. We tend to see, hey, in individuals who have been raped, nurses are like, we see some things that are consistent. Helplessness, powerlessness, guilt, right? Anxiety and agitation. Nursing considerations for when we're looking at patients who have been raped, honestly, watching what you say. Well, you shouldn't have been drinking. Well, what was she wearing? As much as I would like to say statements like this do not occur, they do. If we have someone who's using substances and let's say they have a history of addiction and they get raped, well, she shouldn't have been using substances. Those statements happen more so than we think. When we're talking about treatment and recovery after sexual assault, we have to support the client. We do want to identify support systems. Unless there is a danger to self or others, this patient, once they come in, they get this exam done, they go home. So who are they going home to? Who can they turn to? They might not want to tell anyone. So a good thing if they don't want to talk to someone is referring them to like a support group. Where they can kind of find other people who have had similars, that universality. Other people have gone through something similar and they have gotten better. We can tell our patient is getting better, they're having less nightmares, they're eating better, they're not as suspicious or scared, they're talking to family and friends. Somatic reactions are decreasing, and they're returning to pre rape sexual functioning. After the rape occurs, they may have zero interest in anything to do with thinking about sex, and they slowly start to return back to it. If y'all have any questions, please let me know. Otherwise, I hope y'all have a good day because that's it. We're done with this one.